Hi, my name's Harlan Krumholz. I'm a professor of medicine and public health at the Yale School of Medicine. I want to talk a little bit today about an article that I and some colleagues put together focusing on racism as a leading cause of death in the United States. It's well known that Black people have an age-adjusted mortality rate that's higher than white people. Of course, that's been known for many years. There's been maybe an increasing focus on these issues of disparities recently. The coronavirus has focused attention on this marked disparities during the pandemic, and also the police killings of George Floyd, Breonna Taylor, and many others have been reminders that structural racism persists and restricts opportunities for long, healthy lives of Black Americans and other historically disenfranchised groups. What we've proposed is that to address racism, to really try to make some progress, understand its impact on health, and identify and assess potential remedies, we really need a national set of metrics to galvanize action and, even more importantly, to promote accountability. During the pandemic, a metric, excess deaths, has been used as a key way to capture the full force of the pandemic on society, these excess deaths. We know that disease-specific deaths like COVID can sometimes misrepresent the entire burden of the pandemic. So we've looked specifically at what are the excess deaths compared to prior times, and to use that as a way to understand the kind of progress that we're making. Timely, highly visible reporting of excess deaths among Black people compared to white people could also be a leading government health equity measure. This could represent a start of a way to focus on a metric to which we really measure our progress and where we stand with regard to health equity. Now, excess deaths among Black people really represent the difference over a discrete time period in the number of deaths that have occurred and the number that would have occurred had Black people had the same mortality rate as white people. The excess deaths among Black people can be understood as a toll that is in large part a result of racism in the United States. There's no biological reason why Black people should die younger than white people, why the color of your skin should mark your risk of premature death. Now, the current metrics related to leading causes of death are all related to particular types of death, like cardiovascular disease or cancer. And prevention, mitigation, management of these diseases dominate medical training, and they consume a large proportion of public and private financial resources as we seek to combat these conditions. Each major disease has numerous public health organizations associated with promoting progress and supporting efforts dedicated to raising public awareness and, again, combating those specific causes of death. Now, imagine if one of the leading causes of death was understood as simply being racism within society, and we galvanized that kind of interest and effort and accountability as we sought to make progress. In sheer numbers, the excess deaths associated with Black race, just simply Black race, that is the cumulative excess among all the causes of death, with Black people being higher than white people, would lead that excess death number to be greater, say, for example, for people under 65 than any other cause of death among men, and to be the third leading cause of death for women. So think about that. Being Black, that excess death compared to white people cumulatively adds up to be as large as many of the other traditionally understood leading causes of death. Now, that excess death is made up of many different causes of death, but it's preventable. I mean, there's no reason why the benchmark shouldn't be whatever is being achieved by white people. By the way, that may not even be the best benchmark. Maybe we can even do better. But there's no reason for us to persistently, over time, to have that kind of difference. Now, the American Heart Association has come out with what I consider to be a very enlightened statement around structural racism as a cause of health disparities. And they wrote that the notion that anyone not white is inferior and could be devalued or dehumanized was an important part of creating a culture of racism in the United States that pervades social, economic, and political institutions where structural racism persists today. Now within this country, starting maybe 50, 60 years ago, there began a drumbeat of attention to these disparities. There were researchers, academics, people starting to raise questions. In 1985, the Secretary of Health, Education, and Welfare, Margaret Heckler, issued a report, the Heckler Report, which focused attention on these healthcare disparities. It established the Office of Minority Health. Now, almost every decade, since then. Healthy People 2000, Healthy People 2010, Healthy People 2020, Healthy People 2030. They always put these out 10 years before whatever the health targets that they want to achieve. Each one has said, we need to eliminate racism. And guess what? Over this entire period of time, since 85, when the government first made a commitment to eliminating health disparities, we've made practically no progress. We're almost 20 years now out from a major report from the Institute of Medicine that was called Unequal Treatment, that focused on differences and disparities within healthcare delivery system. And again, we've made practically no advances in actually changing these differences in outcomes by racial groups. The AHA said that several principles emerged from their review. Racism persists, racism is experienced, and the task of dismantling racism must belong to all of society. What they said was that the path forward requires our commitment to transforming conditions of historically marginalized communities, improving the quality of housing and neighborhood environments of these populations, advocating for policies that eliminate inequities in access to economic opportunities, quality education, healthcare, and enhancing allyship among all racial and ethnic groups. People in medicine may be wondering, well, this sounds like societal change. It sounds like issues around poverty and housing and education. What role do we have to play in that? I believe that we also need to be looking carefully at the House of Medicine. We need to understand whether quality of care is being delivered to all people equally, whether we've created opportunities for access that have enabled all people to be able to take advantage of the advances in medicine that are occurring every day. We cannot simply be passive in saying, I'm not racist. We need to accept that our system has been racist for since the beginning of time, and that we need to be actively anti-racist in seeking solutions, both with regard to our own behaviors and in regard to the systems that we work in. Importantly, the AHA said it cannot be accomplished by effective individuals alone. This allyship, the idea that we can all hold hands, work together, hold ourselves accountable, and make progress is essential, And again, if in medical school we're going to teach leading causes of death, we need to have a deep understanding of the role of skin color. It's just skin color and the social determinants around it and the structural racism embedded within our societies and how they ultimately create the conditions whereby there are differences in health outcomes. Ultimately, we have a cause of death affecting certain people in our society. Its causes are mediated through the social fabric of our society. And we must take active steps as a healthcare professionals and a society to address this leading cause of death. That's what we suggested. We suggested we begin to dedicate ourselves, we begin to hold ourselves accountable. We understand and see this role of excess death as something to be addressed. It's time for acknowledgement, accountability, and improvement. We must do this if we're ever to truly get to health equity and an equitable society.